Hello, and welcome to our short lecture on Chapter 15. We'll be discussing globalization in health and how, in many ways, the world is flattening, if you will. We have more integration across countries, across regions, with telehealth and other advents of technology. Healthcare is changing. And so when we think about those changes, there's a lot of different variables that affect the way we receive health services, the way we pursue or seek out certain services. When you think about access to information via your phone and telehealth, when we also consider how resources are maldistributed throughout the United States and globally, you may have to travel to receive a certain service or travel to work in health services. And so globalization is a big piece of that as we see larger communities growing, smaller communities growing into larger communities, different changes in population and population health demographics, health services administration changes. And so we're going to talk a little bit about how the way that we understand patients and patient populations and categorize groups and needs and strategize around that also changes. So right now I feel like with everything that we've been through collectively as a society with COVID, we are increasingly aware of how we're traveling and trends can move very quickly, right? Disease can spread very quickly. Supply chain issues can happen very quickly. And so there's a lot going on in different areas of the world, and we're, I think, a little more aware of that interconnectedness. So this is a picture of a tanker, right? So we've got this ship loading up supplies. We're aware of how much we have that comes from China and Southeast Asia, how much import-export is happening, and how that might impact health, such as not being able to get access to an N95 mask when you need it because the distribution channels have changed. Now, when we say something like the world is flat, I'm not a flat earther, but it's the idea of the variety of forces coming together, kind of creating a great equalization with commerce around the globe. So now we're aware of disparities and differences. We're aware of economic differences, but also we are engaging with people from different backgrounds. We're impacted by changes in different countries very quickly. When you think about the stock market and investments in privately traded healthcare companies, and when you think about product development, most pharmaceutical product development, right, happens overseas. Quite a bit of it does. And so the world of healthcare is becoming flatter, right? Where we're seeing more of a set of impacts, dependencies, externalities between countries. Now, one of those pieces is the flow of patients across borders. Someone may travel to receive different care, more comprehensive, more advanced, more specialized. Maybe something that's a little bit cheaper. Maybe you go to Panama for a hip implant. Maybe you go to Thailand for a brow lift or foot surgery, whatever it might be. So people are traveling. People also travel to the United States for what we call medical tourism. And so that marketing that can occur at a global scale is different. This is a short overview of medical tourism by country. And this is a little bit of a different view because if you look closely, this is the estimated annual number of medical tourists from the US, right? So this is the United States going somewhere. And if you notice, Mexico is at the top, right? And one of the reasons I think it is, growing up in California, I had so many friends who would need dental surgery or would need something done with their mouth, and they would go to Tijuana to have that done because it was so much cheaper and easier for them than seeing a dentist in LA. And so we have to think about the way that those services are marketed and available versus I may travel to India or Singapore for a certain procedure, right? Keep in mind that we have less control if we don't know the language or if we don't know the safety protocols, right? There's some inherent risk with any travel. But this is just an example of how both high and low GDP countries are competing for patients now. Now, when we think about that outbound patient flow, wealthy patients from high GDP countries tend to travel back travel to other countries because they lack comprehensive health services. So if I'm in the United States and I want to have an all-inclusive experience with a surgery and stay in a nice resort environment and have certain services, I may go to a medical spa in Thailand or Mexico, right? Because that makes sense. But the outbound patient flow happens quite often in countries with huge disparities between rich and poor. So somebody from India, for example, or somebody from South Africa may come to the United States for a service, right? That isn't available as comprehensively or as safely maybe in the city that they live in. Patients from high GDP countries with relatively expensive healthcare services, such as if I need a hip plan in the United States, I may choose to travel to India to do that or to Thailand for a discount. Now, those are just examples. This is a quick table that looks at the percentage of travel to and from. So if we look at from Africa, most people in Africa who travel for medical tourism travel to Asia. If we look at from North America, most people from North America, 45% go to Asia, 26% Latin America, 27% other North American countries like Mexico or Canada. So you'll see it's a very interesting layout when we look at the travel. Now, cost comparison is part of why. This is dated data. It's from your textbook, but it makes a great illustration because these trends are still true. So if I wanted to have a CABG in 2008, a coronary artery bypass graft, which is even more expensive now, but let's say it was $25K, now it's $32, $35K, just to have the heart surgery, not including the hospital stay and everything else. I can have that done, right, in Singapore for 16, in Malaysia for 12, in Panama for 10. Now, I just said cost $25K to $35K. That's the Medicare reimbursement rate. What they bill fee for service is that first United States column, which is the average hospital charge, which is up to $133,000. So you can see travel might make sense if there's money to be saved for certain populations. Now, patients from countries with long waits, like Britain, will consider traveling to the United States. For example, if I'm wealthy and I live in the UK, I may come to the United States for cancer care. I once met a gentleman who had waited 18 months for colon cancer care, and he decided to leave. This was years ago. I'm not disparaging their system. I'm just saying that he needed a very specific surgery and had been waiting. And so he came to the United States and paid out of pocket for that. So keep in mind that that's part of that exchange too. Now, why are we talking about this in an organizational behavior class? I think this has a lot of implications for patient flow. So when we think about people traveling between countries, we think about the volume of people entering our facility, people who are visiting, right? That impacts how we manage our organization. Do we need folks who speak certain languages, have certain cultural competency? Do we need to be networking and marketing ourselves with groups that coordinate travel? Like, how does this change health services? And how do we make sure that we're also aware as patients and receivers of care of the instability and the risks that could come with going somewhere else? And I'm not saying that other countries don't provide excellent care. I'm just saying that anytime you're in a situation where you don't speak the language or you're incapacitated, right, there's inherent risk. So as a healthcare manager, a lot of factors are out of our control as far as how many patients come in our facility and driving up our volume and capturing as much value as possible. But this is one area where we can do some work. Now, medical tourism does raise some ethical issues. False advertising and fraud can happen. Also, if we want to attract international patients, quite often facilities will create these delighters. They'll create a fancy waiting room. They'll market certain specialty services and spa treatments and facials that come along with, while you're waiting. And that's great, but that doesn't help us channel money to the underserved and necessary healthcare services. So there are some limitations and some challenges with choosing to market yourself in that manner. Now, the other piece that I want to talk about, we've talked about the flow of patients across borders. I want to talk for a moment about the flow of healthcare workers across borders. The labor market is more globalized than we realize. A lot of nursing staff and other skilled staff come from other countries. They're crossing national boundaries in order to receive well-paid work and stability. And that's wonderful, but we have to keep in mind the negative externalities and the impacts. So high-income countries like the United States recruit workers from other countries, right? Where I live, we have a lot of Filipino individuals, a lot of individuals from different African countries that provide health services that are nurses. Now, as those people are coming into the country, there are some things that we're not thinking about I remember when I first started learning about immigration and thinking about it from a social justice perspective, I was like, why don't we let everyone come to the United States? Why is there a waiting period? Why? If every skilled nursing professional, every nurse with skill who's received an education in Africa, every physician was able to come to the United States and build a little empire for themselves, right? Build a family and a legacy and the American dream, which is wonderful. There wouldn't be anyone there. So I'm not saying that everybody wants to come to the United States. That's certainly not true. But the high income countries that can pay well for workforce are taking resources, if you think about it that way, from other countries. And so we have these resource deprived countries. For example, I have a student that went and was part of an effort to set up a school in Nigeria, a nursing school. But then if half of the nurses who graduate in Nigeria, where those services are needed, come to the United States to work, right? They didn't make that area much less resource depleted, right? They sent us the workforce. So it's something to keep in mind. Now, when you look at countries with the most foreign trained nurses, we are at the top. This is 2018 data, but you can see United States, Britain, Germany, all the way down. Now, there's some financial implications, right? An exodus of healthcare workers from low and middle income countries can impact that country's economy. And so our response is something called managed migration, where we regulate the flow of health workers. But this is difficult, right? There's lots of different perspectives. And when you think about it from a microethics perspective, of course, you want every person to be able to build the life they want. But how do you respond to that? And so this is an interesting little article overview that I linked in here that you might want to take a look at. The graphic that you can see here is looking at educational attainment amongst U.S. immigrants, bachelor's and post-bachelor's degree. And if you look, almost 20% of United States immigrants have a bachelor's degree from where they're coming from. And about 15% have some sort of postgraduate degree. And so what that tells us is that these are folks who obtained an education elsewhere and are coming to do skilled or focused work, right, here in the United States. I don't think most people realize what a high percentage it can be. Now, how do we then staff up appropriately as healthcare managers, compensate people appropriately, maybe market job opportunities globally, but with an ethical lens, right? We have to have workforce planning. We have to make sure we're compensating folks effectively. We're incentivizing them with bonuses and recruitment bonuses and retention bonuses effectively. We've got HR processes in place and linguistic and cultural competence. We have flexible pay systems for people that have to send money home maybe, and more accessible and shorter training for people who are coming from overseas and need specialty physician training or training to work in the U.S. When they already have degrees or specialist training in other countries. So many ways we can help strengthen low-income country health systems is maybe a monetary tax. Maybe we pay a recruitment tax to the source country. So if we're getting a lot of nurses from South Africa, maybe there's a small amount of money that goes there for every nurse in order to restore that economy. Maybe capacity building. Maybe we contribute actually through programs to that source country and create the schools and opportunities, right? Now, the other thing that's very interesting about globalization, outside of the movement of patients and the movement of employees, is the movement of information and processes. So in 1983, the first patient classification system, the DRG system, came out, where we stopped paying for every little individual service in a hospital and we started paying based on a diagnosis-related group. You are a stroke patient, we will receive so much reimbursement. You are a hip fracture patient, we receive so much reimbursement. That idea was adopted in the United States, right, in 1983. Those types of practices and policies, payment mechanisms, quite often we are sharing and or adopting those from other countries, right? And as you know, we're a little behind when it comes to universal care and some of those pieces. But sometimes management practices are also adopted from other countries. So we have to think about that as part of globalization. So the other thing when we think about the DRG related group, the way that we classify people and hospitals are reimbursed based on the type of diagnosis of their patient, that did spread widely around the globe. And at a macro level, that cost containment effort of, we don't reimburse the hospital for every Tylenol and every towel and every nursing shift. Instead, we pay based on DRGs, and the hospital has to manage their cost within that framework, being paid based on you're only going to get $22,000 for the stroke patient, make it work. That has spread to other countries, and that has helped other countries contain cost of care. We're still working on leveraging our own idea effectively, I think. When we think about the flow of patients and ideas and policies across borders, there's some major barriers with that, right? We have certain regulatory, political, economic, and cultural norms in the United States that maybe there's a great idea in Korea and we don't adopt it here. The flow of our payment system externally has been really interesting to see for United States health services managers, but our ability to adopt and implement international ideas, right, is likely an area of growth for our health system, right, to reflect and see what other countries are doing well and incorporate that. Now, a good example is sunscreen. If you wear sunscreen manufactured in the United States, it might really burn your eyes. The FDA has not approved a new formula for the way sunscreen is formulated and SPF is calculated in many years. If you wear Korean sunscreen, for example, it is much smoother. It goes on like normal lotion. It doesn't burn your eyes, many brands. That's because that country has prioritized that and has developed that product. Well, our regulatory landscape with FDA approvals for products hasn't caught up with that yet. So it's interesting when you think about the flow of products across borders. There's a lot of considerations to think about. The flow of information, what is being adopted from and in the United States, right? Who is coming to and leaving the United States, healthcare workers, patients. And a lot of that is hard to track, right? I don't know necessarily how many patients went to Mexico this year for a dental procedure, right? So we sample, we send out questionnaires. There's different ways that the United States captures data, but it's not perfect. But not all flow of individuals is positive as the health system grows. So we have to make sure the way that we are coordinating services, the way that we are hiring is ethical and appropriate, and keeping in mind the impact both domestically in the United States and internationally. And then, of course, I begged the question a little bit earlier. I said, COVID has changed our awareness, but now I want you to really think about how it has changed globalization. Right? I think that we used to think, we could just order it and that shows up from Amazon, from China, boom, done. And then during COVID, it was like, it took 6 weeks to get a package. Is it the mail provider? Is it the individual on the other end? We're aware of how many people are touching and engaging with a process, right? So when you think about the work that it takes to develop a medical product and ship it overseas and do all of those things. All right. In many ways, healthcare is still a local business, right? I go down the street to my doctor in many cases. In some ways, it's not with telehealth. So local practice patterns and health-seeking behavior, who utilizes what service locally, we have to keep that in mind, right? But Chapter 15 is showing us that there's this globalization push, that things are changing. And we want to encourage the spread of appropriate technologies, practices, approaches to delivering high quality of care and discourage the spread of those that aren't appropriate. All right, well, thank you so much for listening to this short overview. I hope it was helpful for you. I enjoyed sharing. Please reach out with any questions and have a wonderful week.